Morning, I'm Johnny Mathews, 7 Registrar, and I'll be presenting a cadaveric assessment of Toka, a novel personalised system for high tibial osteotomy. Now, high tibial osteotomy represents a useful surgical option for medial compartment OA in younger, more active patients. It is technically demanding, and accurate correction in multiple planes is essential for optimal effectiveness. Challenges include the need for intraoperative imaging, reliability of correction, procedure lengths, and soft tissue irritation. A new system has been developed by a team of Bath engineers to address these challenges. It is named Toka, which stands for Tailored Osteotomy Knee Alignment. The system involves a preoperative planning process following a CT scan and 3D printing of a cutting jig and titanium plate, which are both patient-specific. This flowchart summarises the preclinical development process for the Toka system, including finite element analysis and a virtual trial which have been presented previously. This paper presents the results of a final ideal preclinical stage study of Toka ahead of first-in-human surgery. So the aim was to assess the accuracy of the Toka system for opening wedge high tibial osteotomy in cadaveric specimens. 4 cadaveric legs underwent initial CT scanning and 3D construction. Custom software was used to perform a virtual osteotomy and then to design a custom cutting jig and plate for 3D printing. All 4 cadavers underwent OWHTO under simulated conditions in the Bristol Vesalius Centre. The procedures were performed by the senior author from Exeter knee team with a surgical assistant. Then postoperatively, a further CT scan allowed 3D assessment of the correction achieved for comparison with the preoperative plan. 3D assessment allowed evaluation of 3 variables. Firstly, the gap opening angle, which quantifies the angular opening of the osteotomy gap itself. Secondly, the anatomical orientation, which reflects the positioning of the osteotomy relative to the anatomical axis of the bone. And thirdly, the positioning of the osteotomy vertically and horizontally, which gives an indication of jig placement accuracy. So, with regard to the gap opening angle, the average difference between the preoperative plan and the postoperative achieved cut was 0.74 degrees in the coronal plane and 0.62 degrees in the sagittal plane. When considering the positioning of the osteotomy relative to the anatomical axis of the bone, there was an average difference between the preoperative plan and achieved cut of 2.53 degrees in the coronal plane and 7.35 degrees in the sagittal plane. And finally, when compared with the virtual plans, the achieved osteotomies were made with a mean difference of 2.34 millimeters vertically and 1.54 millimeters horizontally in the coronal plane, with a mean error in the sagittal plane of 1.67 millimeters vertically and 1.61 horizontally. Now, this work does have limitations. The number of cadaveric operations performed in this study is obviously small, and there were no control cases to permit comparison. However, the aim of this study was to explore the reliability of the Toka system in the preclinical setting, and which has shown that we can get accurate correction comparable or even better than some of the other series whose references are listed here. The 3rd and 4th cases were performed skin to skin in around 30 minutes, which was a significant improvement on early cases. And it's important to recognise this cadaveric study represents just one component of the preclinical testing. Things have progressed well since this study, and the system will shortly be evaluated in the PASSION multi-centre trial coordinated by Oxford Trials Unit.